Hi, good afternoon, everyone. Thanks for joining. We'll talk about septic cardiomyopathy for the next sort of 45 minutes or so, which is obviously a pretty common topic that we see on a day-to-day basis, but also really commonly brought up in the exams. So I'll try and keep it quite exam-orientated to begin with, and that's because it keeps things nice and simple and sort of in a nice, easy way to answer things for an exam. But obviously, it's a pretty controversial topic and not brilliantly defined, in my opinion. And that's when the interesting bit comes on, which we'll talk about at the end in terms of actually clinical management of these patients. So let's just start off with talking about some echo features of, the myocardial issues that would happen in sepsis. And can I just ask for maybe just you guys to shout out a few? Why don't we just start with Ben? We'll start off with you. You're starting off doing the DDU stuff, so you get the first choice, first bite at the apple. Give me something that can go wrong with the heart when you have a septic episode.
Am I allowed to just say decreased contractility?
Beautiful. So the LV can be down. All right, beautiful start. Sid, give us another one.
So RV dysfunction.
Nice. So the RV can be down. Beautiful. Swapnil, Tejo, give us another one. And it can be anything, not just myocardial depression. So you said the LV was down. What do you give us another? Expand on that a bit.
Hyperdynamic to start with.
Sweet. So the LV can be down or the LV can be up. Beautiful. And what about Benny? Your favorite topic? If it can be systolic, it can also be obviously
diastolic.
Diastolic. Fantastic. And tell me about the left atrial, the sort of left atrial pressures.
Sorry, what was that?
Tell me about the left atrial pressures, because we often say we've got diastolic dysfunction.
Yeah.
But what do you think?
So in a grade 2 diastolic dysfunction, then you get raised left atrial.
Yeah, nice.
Yeah.
Beautiful. And then it can often say that you've got normal filling pressures sometimes. The definition can also be. So I think it can be a bit of both, right? So sometimes just the same as you can have the LV systolic function can be down or it can be hyperdynamic. Same thing can be said for the diastolic dysfunction with left atrial pressure, that it can be normal or it can be raised. Nice. Then I've got some other ones. I set the P and hang on, that's me. Who else have we got here? Arne, give us some ideas. Give me another thing. So it's getting a bit harder now, isn't it? So we've got people saying we've got hyperdynamic LV function. LV can be bad. That can be systolic or diastolic. Give me another characteristic. Like, how long does it, how does it last?
The LV diastolic and diastolic volume can be up, and the LV and systolic volume can be up and there may or may not be change in the stroke volume. The same is true for the right side. And then resolution would be typically 7 to 10 days.
Fantastic. And yeah, I think that's a pretty good list that we've got there, to be honest. So for the exam purposes, if they come up, so just getting one more person admitted.
What about LVOT obstruction, Sam?
Nice, fantastic. So I think this is where the last bits are going to come in, which is talking about the hypovolemia, because I think the next thing which we commonly see, and this is where the literature is getting a little bit better more recently, is that particularly if you're getting sort of hypodynamic function, or you're typically getting these people with massive vasoplegia, you can often get a hypovolemic state pretty quickly, and you can get people who get LVOT obstruction. So that'd be another fairly common thing that we'd see. I just quickly manage, I can't do two things at once. Beautiful. Try that. Oh. Yes, LVOT obstruction, particularly if it's often sometimes difficult to tell with and we'll discuss this a little bit at the end about the LVOT obstruction versus the mid-ventricle obstruction. So getting some form of hypovolemia, absolutely, it can be a feature of septic cardiomyopathy. And on the flip side, I think we've all seen people maybe a little bit later on in their stay when they're hypervolemic or they're fluid overloaded, maybe that's a better way of saying it. And we know that that's a bad thing. So I've just kind of put this together as a little bit of a brain, memory thing about the prognostic implications of some of these as well, based on the evidence. And this is all based on some of the best evidence we've got where I've written these, but I think there is a lot of problems with this because the evidence sometimes doesn't define septic cardiomyopathy very well. And often I think some of the studies, including some that I've done, are pretty dodgy because they're just like a snapshot. You talk about septic cardiomyopathy, you know, this is associated with it. We're often doing echoes like on day 1 or sometime within the first 3 days. And then we're using that to define a very, very complex alterations in your cardiovascular physiology. And so I think we've got to take some of these with a pinch of salt, and we get a chance to maybe talk a little bit about the research and where we need to go at the end. So, as I was saying, LV dilation has been shown to occur, and that's often associated with maybe bad prognostic factors. LV dysfunction can be both systolic or diastolic, and the diastolic's probably been suggested to be associated with more prognostic implications versus systolic. RV dysfunction can occur in about 1/3 of patients, and again, that's associated with maybe a bad mortality, particularly if your RV is badly affected. As Benny was saying, we're going to see diastolic dysfunction. You can have raised left ventricle pressures, you can have normal left ventricle pressures, and you can have low LV filling pressures. And a lot of that stuff, I think, comes from because we're not very good at defining these with echo, I've got to be honest. As Arne was saying as well, it's transient. So the idea is if you've got a normal heart, you then get some form of dysfunction from sepsis because of direct effects on the heart or because of impairments in your afterload or whatever. And that would hopefully then go away. And if it goes away, obviously it's better for your survival. Again, one of the problems with the literature is that often we haven't got these follow-up studies, and we often don't have any echoes from beforehand. So we say it's transient, but most of the time in these studies, they've never, you know, it's really difficult to exclude people that ever, you know, say that you can only have people, for example, who didn't have cardiac dysfunction before. It's quite hard to make that as an inclusion criteria. So most of the studies that I've read, certainly for septic cardiomyopathy, they have no idea what people's pre-sepsis heart function was. And then most of them also don't really do that many follow-ups afterwards. So it can be a bit hard to know that, but the idea is that septic cardiomyopathy from the exam point of view it's transient in the majority of patients, and that's a good thing, obviously. Hypovolemia, fluid overload. I probably don't need to talk to you guys too much about those to say that we've got evidence not just in septic cardiomyopathy but in just critically ill in general, that if you're hypovolemic with raised lactates and everything, that's not a good thing. If you're fluid overloaded, particularly if it's sort of over a prolonged period of time, that's also been shown to have mortality implications. So if you're asked about, just in summary, that's what I'll be putting down as an exam answer for septic cardiomyopathy, talking about LV size, LV systolic function, LV diastolic dysfunction, RV function, filling pressures. It's transient, so it affects both ventricles, and it's transient, and hopefully if your heart gets better, that's a good thing. And it's also associated with fluid status. Okay, so let's show a few cases about that so that we can discuss that a little bit further. Any questions so far? Because that's kind of the talk in a nutshell. Okay, we'll carry on. All right, so it's a friend of mine, Juan Pulido, who's a pretty smooth South American dude, who's did a study in about 106 patients, a single center study out of the Mayo Clinic up in Rochester, Minnesota. And they've got, I think they've got 4 or 5 different ICUs there. And he took all the patients in those ICUs, and those with severe sepsis and septic shock by the old definition. He just looked at their echo, and it was done within 24 hours. 106 patients, quite nice sort of Venn diagram showing that you can get a collection of all these different kinds of dysfunction, both for the RV and LV systolic and LV diastolic. And it's about 30% across all of them. So about 30% of the patients are getting some form of LV systolic dysfunction, about 30% getting some form of RV dysfunction, and approximately 40% getting some form of diastolic dysfunction. And overall, about 65% or 65% of those patients have some form of myocardial dysfunction. And I think that sort of fits with what I see clinically. I think that sounds about right to me, and I've got similar data from when we've done it. But again, the difficulty is on what parameters you're using to define these. And maybe we'll get into that a little bit later if we have time, because you know, you say LV systolic dysfunction. If you base that on ejection fraction, it's one thing. If you base it on MAPSI, it's another. If you base it on strain, it's another. If you base it on, you know, tissue Doppler, it's another. And I think this is one of the problems that we've got, is that every single study seems to have a slightly different way of defining defining dysfunction, and that obviously makes it a bit tricky to try and look at all the data together. So let's start off with a typical patient that we'd have in our unit. So we've got a 48-year-old guy with meningococcal septicemia. He's been increasingly unwell over 2 days. He's a collapse, reduced level of consciousness, and he comes in and he's sick as a dog. So he's hypotensive, he's got lactates of 5, he's horrifically acidotic, he's in shock, no obvious past medical history that we're aware of. Does that mean that he's never had any cardiac dysfunction? It's obviously hard to say, we don't think so. And he's put on some noradrenaline, and he's got rapidly escalating noradrenaline requirements as he comes into the unit. And these are the kind of guys that go and have a look at their heart so that we can see if there's any kind of underlying myocardial dysfunction, and if there's any kind of LVOT obstruction, or if there's any kind of resuscitation that we need to do, either over or under resuscitate. Okay, what should we start with? Arne, are you happy to kick us off with some of this stuff? Oh, you're still muted, buddy. Thanks, mate. You good? Do you want to...
Can you hear me now?
Yeah, I can hear you.
Okay, so that's a parasternal long axis view. The LV appears dilated, but I would need to measure it with normal wall thickness. The LV function is moderate to severely down, maybe on that single view, and AF around 30%. The RVOT, well, it's a bit hard to judge whether it's also a little bit down. The aortic and mitral valve opening nicely and unrestricted. And then you're showing me a M mode from the mitral valve.
And you've got an internal diameter of 63. What do you think of that?
Oh, sorry. Yeah, the diameter is up there.
Yeah, sorry.
So 63. So it's probably dilated, but depends a little bit on the body surface area. So for a male, that would be 3 indexed. That would be the cutoff. So it depends a little bit on the body surface area.
Yeah.
But the end diastolic volume also is. Oh no, that's probably not the good volume measurement there.
Yeah, exactly. Very nice, very nice. So I'm going to come on to that in a sec. So first of all, 63 millimeters. So you're absolutely right. It's dilated. And just give me mild or severe.
That would probably be mild in that category.
Yeah, fair enough. So it's a mild to moderate category. Beautiful. And you talked about the volume being inaccurate, and I totally agree with you. But I've also got an ejection fraction here of 43. So you said you thought the ejection fraction was 30%, but I've got it here as 43 by my M mode. Which one should I go with?
Well, it's the only standardized ejection fraction is by biplane with Simpsons, so yeah. I wouldn't give much to that.
Fantastic. So this is done by the take or the Teichholz method. And why is it inaccurate? I mean, how are they getting that measure? How are they getting that ejection fraction of 43%?
So it's just based on the fractional shortening. Yeah. So the incoming linear value at the basal segments, which may or may not reflect the overall ejection fraction.
Yeah, and so they're extrapolating that through an ellipsoid mathematical equation. They consider the LV to be a certain shape and a certain length, of which it doesn't take into any account of that. And obviously taking 2 points of an ellipsoid structure and considering its change from that to that, they get their ejection fraction. And that can be grossly inadequate, as you were saying. And I think also talking about regional wall motion abnormalities, and that can be another major problem that it doesn't take into account. So completely, I don't think we use that. I think your estimation of 30% is much more accurate, and I don't use these at all. Okay, what do you think here?
All right, so these are the short axis views, basal, papillary, and an apical view. Now, first of all, the RV seems dilated on those views.
Nice.
Still seems a global pattern, and it's reasonably cut. Whether there's a little bit of abnormal septal motion, and the QRS complex looks narrow.
Right, so what can cause that? If you've got a normal QRS, what else can cause your septum to bounce?
So you definitely want to consider the clinical context, whether there's was the RV dilated, whether there's some other underlying pathology or pulmonary hypertension. What is the, are there pulmonary infiltrates? What's the ventilator set at? Or we already said that there's no adrenaline running.
Nice.
All of those things could play into that.
Yeah, very nice.
Otherwise, the ejection fraction, look, it's probably stick to sort of a similar judgment. Maybe it looks a tiny bit better there, but it often does in the short axis. So
yeah, completely agree.
I would wait.
Nice
for
comment. So
more
just to
views to
summarize,
see.
so you were summarizing, you were saying that the RV also looks dilated. We've still got a global LV sort of decreased function pattern, which again can be associated with septic cardiomyopathy. We've got a little bit of a septal bounce coming in there, which could be related to a dilated RV, because you think the QRS complex is narrow, because obviously if the QRS gets widened, we can get a septal wobble, and the function looks severely depressed. And often you say it could be moderate, and often it does look better in the short axis. Very nice. Yeah, I guess 35%, so it's kind of sitting with where you are. Probably on a second look, I think I'm probably leaning towards 30 as well. Just in the meaning of time, I might crack on, because I don't think you're telling us, I don't think this will change anything you've said. And again, maybe just I'll add in that we're not seeing any obvious regional wall motion abnormalities, and this looks like more of a global picture, just as you said before. Beautiful. What about this?
Now that's a mitral inflow view, and then the tissue Dopplers. So let me go through this. So the E velocity is around 50. What does it measure? 51. So it's
about 0.5.
It's quite low, but the E over A is 2.5.
Yeah.
Which would suggest elevated filling pressures in the left atrium.
Very nice.
Yes, or an elevated mean left atrial pressure. Would be good to know. I've forgotten the age of the patient. The patient was quite young.
49.
49. Well, it probably still is, even 49 to 2.5 is quite elevated. And then the E prime velocity medial is measured at 5.
5, yeah.
That's down, and that's the S prime RV. It's also down. So that's consistent with what we have seen. So there's also diastolic dysfunction in this setting, which is not surprising. I mean, that's per definition with the reduced LV function.
Yeah, very, very nice. And I think, just remember these numbers as we go on to the next slide. So we've got an E to A that's greater than 2, which suggests severe diastolic dysfunction. We've got an E to E prime that is less than 15, which suggests that we don't have elevated left atrial pressures. We've got a left atrial volume that is normal, that goes against the diastolic dysfunction guidelines. But the problem is with these patients is that what potentially we're dealing with is acute diastolic dysfunction. And then we've got a TR velocity, which is greater than the 2.8. So this is all fitting in with these guidelines that are freely available. And I think they're on our little Dropbox little group, which these are the guidelines that I kind of follow for patients that have systolic dysfunction, or they've got some form of hypertrophy and normal ejection fraction. So anyone who's got some form of structural or functional abnormality to the LV, this is the guidelines would suggest. And they're great. They're the most robust guidelines that we've got. Unfortunately, they say in black and white somewhere in the document that it's not really validated in the perioperative or critically ill situation. So this is the kind of best that we've got. But the problem is that I don't think we can use the left atrial volume index quite as well as they suggest in the guidelines. The E to E prime, the left atrial pressure can be normal despite having diastolic dysfunction. And so again, I'm going to agree with what you were saying. One of the little things that you mentioned in there was that this was really important to you, looking at the E prime that was less than normal, which is 8 of the medial and 10 in the lateral. That's sort of the cutoff to say that something's abnormal. That's a really important parameter for me to look at, because it's
Sam.
Hi.
Sorry, if you have RV dysfunction, then and septal abnormality and movement, then the medial measurement might not be representative.
Absolutely, and that's why I suggest that we're using an average of the two of them is always what we're doing. If you've got regional wall motion abnormalities, you also probably can't use that value as well. So yeah, great comment, I think. So we've got to be careful with the RV dilation and making sure that we're averaging it, because here you can see that this is the RV parameter, so I've got over there. I can't remember what the lateral was on this guy, but averaged together it was about the same, because we got a 5 here, it's 0.5, it came to a E to E prime value of 9. So exactly, I think we've got to take these things into consideration, at least when we're doing it. But I guess the main point I was trying to make is that the best guidelines that we've got, we sometimes don't exactly fit beautifully into it, but we still use them. But I think you've just got to take in mind that we've got to use all the parameters at our disposal. I guess that's what I'm trying to get at, and take the clinical context into consideration. And we've got to understand that what we've got is not perfect. Yeah, hi.
I had a question. Like you mentioned, it's acute diastolic dysfunction, and that's why the left atrial volume may not be high. But
maybe, yeah.
So it's like a non-compliant LA situation. So the pressures would in fact be higher, isn't it?
Yeah, they absolutely. Yeah, completely nice question. I mean, I guess it's going to depend a little bit on the fluid status there, but absolutely, if you've got an acutely impaired diastolic function, you're suggesting that therefore if you've got a poorly compliant left atrium, the pressures could be even higher.
Yes.
Yeah, and we have no data to kind of back a lot of this stuff up, because obviously what we need are invasive measurements, and that's ethically got a bit of a complication factor in there, because the best that we've got some of these things is based off pulmonary artery pressure, pulmonary artery occlusion pressure, which isn't magic. So I don't know the answer to some of those questions, I've got to be honest. All I know is that the left atrial volume in patients that have got parameters such as we've seen, which probably suggests some form of diastolic dysfunction, because we've got systolic dysfunction, I think by definition we've got some form of diastolic dysfunction, and some of the parameters just they're not perfect. Benny, I don't know if you've got anything else you want to add from there as our expert on diastology.
No, and I'm not an expert.
Yeah, we'll take it though. Yeah, I don't think Benny, do you think there's anything else to add in there? I mean, other than to say that I guess the literature that I've read suggests that the left atrium maybe takes between 2 to 4 days to dilate. So that acute diastolic dysfunction can give you a normal left atrial pressure, but if you continue with that kind of pattern, after about 2 to 3 days, you will start to see some LA dilation, but it doesn't happen like that.
Yeah, volume. Yeah, like so. I guess in the acute period, you could have a normal looking LA size, and then, like you said, it would take some time to dilate, and then really the LA pressure would be dependent on the grade of diastolic dysfunction that you have, because by definition, grade 1. Like just as you have it there, grade 1 has a normal LAP, and grade 2 has raised LAP and grade 3 after that. So, I mean, but again, like you said, that's not really validated in this population. And as we've discussed previously in the DDU teaching about diastolic dysfunction that Prof did earlier this year, there are significant limitations to these parameters that we use even in a normal population. So yeah. I think take everything with a grain of salt. I like the E prime as I think that's a really good indicator, because it's quite linear. It continues to go down with worsening diastolic dysfunction. But again, you'd need sort of like longitudinal studies of the same patient,
yeah,
rather than absolute values. And then it has the same limitations that was it Lewis that mentioned?
Yeah.
Yeah. So it's hard to know. I think just like you always say, see the whole heart. Don't take one indicator. And yeah.
Thank you. All right. So here we can see that we've got an IVC that is 19 millimeters in size and doesn't collapse with insufflation. and we got a TAPSE that's somewhere between 11 and 14 millimeters, suggesting again what Arnie was saying in terms of having some form of RV dysfunction, and we saw some dilation on the other image. So in terms of fluid status, I don't know. I don't think the IVC is adding a great deal to that. But let me just summarize before we can move on. So I thought, looking at that echo and that clinical picture of a 49-year-old guy who's in shock, we had what could appear to be a septic cardiomyopathy. But am I absolutely 100% sure on that? No, I'm not, because I think we've always got some other diagnoses to consider. So I thought the differential with septic cardiomyopathy would be number one. Could it be some form of direct myocarditis? Yeah, but meningococcal meningitis sounds pretty rare. Could it be a viral meningitis that we're dealing with? Yeah, maybe, but his serology was normal. Could it be some form of pre-existing disease where you had no past medical history, but, you know, funny things have turned up, haven't they? So the only way to try and find out if this is something to a pre-existing disease is to treat him as a septic cardiomyopathy with supportive care, early antibiotics, resuscitation, avoid fluid overload, untropic support, blah, 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 usual stuff that we do. And then we see how the heart responds over time. But I guess this is the kind of person that could easily be included in a study as a septic cardiomyopathy, but we wouldn't be 100% sure that he definitely would be. And that's one of the problems that we've got with the literature. That's all I was trying to get out of that one. Okay, let's do another one. Who wants to go next? Who else have we got? Swapnil and Tejo, do you want to have a go at this guy? If you're up for it, you don't have to.
I think get other people to I think I'm pretty at baseline level. So
no problem. Can we pick on Danielle in that case, because she's got her exams coming up? Danielle, are we allowed to pick on you? You knew I was coming, right?
Yeah, that's okay. Yeah.
Good on you. Okay, 51-year-old female. She's got severe community-acquired pneumonia, septic shock, and developing an ARDS pattern. So 4-quadrant infiltrates on the chest X-ray. You can see she's got peak pressures or plateau pressures at 27. She's got peeps of 10. FiO2 is only 0.4, but she is a little bit on the tachycardic side. She's got a CVP of 115.
Yeah, that's a bit concerning.
That's a bit concerning, yeah. And she's got a blood pressure of 95 on 60 on a lot of support. And she's on noradrenaline and milrinone at day 2 and in shock. Okay, so pretty sick. Go for it.
All right, so this is a parasternal long axis view. The LVs, so that, look, I think it actually doesn't look as bad as I was expecting it to look.
Exactly right.
The RV, the aorta, the LA, they're all sort of, you know, equidimensional, so probably not, there's no evidence of significant RV dilatation on this particular window at the level of the RVOT. The LV wall thickness and cavity size appears normal. I'm not getting a really good image of the anteroseptal wall there, but the infralateral wall appears to be contracting and thickening quite nicely. So this doesn't show evidence of severe LV dysfunction. The aortic valve and the mitral valve appear to be normal leaflet thickness and probably moving quite normally as far as I can tell from these images.
Yeah, nice. Keep going. What else are you seeing in there? Don't miss the outside. Don't miss the rest of the picture.
So posterior
low, right?
to the heart, I think we're seeing a slice of lung there,
Yeah.
which probably is consolidated in these images. I think we can see either some shred sign or some bronchograms down there behind the heart.
Yeah, beautiful. And first, just starting it sort of down in here is what you're talking about, almost like hair bronchograms that are sitting at the back, and all this sonographic hepatization where it looks like the liver. And obviously, this should all be just grey and sort of a dirty shadow behind it. And if we can see stuff, that's abnormal. Very nice. We've got a normal diameter here. Internal diameter dust is 43, so greater than 58. I'm starting to get concerned. So that's definitely normal, and the function looks normal. So we got someone who's sick as a dog with a very different heart compared to the last one. What about this one?
Okay, so it's a parasternal short axis at a level of the papillary muscles, I suppose. The image I'm getting through is very jerky, but I think I am seeing some septal flattening there. I think during diastole.
Nice.
And
so
I can't say for certain actually whether the RV is dilated on this view. It's not obviously dilated, and I'd need to look at the apical four-chamber, I think, to make a better judgment about the RV size. The LV, I think, looks like it's contracting pretty well. So yeah, just with the septal flattening there, that may be suggestive of RV volume overload.
Sweet. So diastolic flattening of the interventricular septum suggests volume overload. Systolic flattening of the interventricular septum is suggesting pressure overload. Yep.
It looks like it's fine.
Yep.
So a little tip and trick. So Louise is here, and Louise's comment was saying it looks like it's a little bit of both. And could be due to the slice. So particularly we'll need to have a look at it in other views to back it up. But one of the ways that I kind of try and check this out is, can you see my mouse? I put my mouse is where I'm looking at with my eyes. So, and then I use my peripheral vision to have a look at how the heart contracts. And then I can get an idea of whether that flattening is happening as the heart is relaxing or as it's contracting. So when I'm looking for things like LVOT obstruction or septal flattening, don't look at the thing you're after, look away from it and use your peripheral vision so you get an idea of the movement. That's, I don't know, I don't know if it works for you, but it's how I sort of do it, and it helps me try and pick things up.
Yep.
Just in time, I might sort of flick through this one. So here we got someone who's got the normal E to A ratio, normal E to E prime. We've got an E prime in the septum, which is 11, and in the lateral, which is 14. So this would suggest normal diastolic function and normal left atrial pressure. So again, it's a little bit different from the last one. And here you said you thought that, let's focus on the right ventricle a little bit more. So you said you thought the right ventricle might be dilated and might not be working perfectly. What do you think with these views now?
Oh, look, it's really difficult. I'm not sure if my internet connection is working the best at the moment.
Maybe I can say the RV looks about the same size as the left ventricle.
Yeah, so mildly dilated, and the TAPSE there of 15 is just below the normal limit. So yeah, it's not quite normal, but the changes are pretty mild.
Beautiful. Okay, and so this is my next picture. And what am I trying to show here? Because this guy's on escalating levels of support. We've got a normal LV function, and she's pretty sick. What's this?
So this is the LVOT VTI using PW Doppler, and what we're seeing is that the VTIs are pretty variable. So we've got a maximum velocity anywhere between sort of 1 and like maybe 0.6 there, and so the question, I guess, is it that the stroke volume is actually varying with respiration, which might indicate inadequate preload, I suppose, or possibly ventricular interdependence. However, the thing that concerns me a little about the waveform itself is that on the waveforms where the VTI appears to be lower, you've also lost the closing click on those particular waveforms. So is it that the stroke volume is varying with respiration, or is it that the heart is swinging in and out of the correct alignment that you're trying to get when you're doing the pulse wave measurements?
Really great, Danielle. Fantastic. Absolutely. So I don't have anything to add to that. That's beautifully done. So what you're saying is that you're concerned with this massive respiratory variation in blood flow coming out of the that left ventricle. That can suggest that you're on that ascending portion of the Frank-Starling curve, and so that you would be fluid responsive if we gave you fluid, as in saying that we would increase that stroke volume if we gave fluid to this patient.
Yeah, it's like another way of demonstrating stroke volume variation. Well, it is demonstrating stroke volume variation.
But the problem you're saying is that with the patient breathing, the heart moves around a bit, and maybe we're moving our probe as we're getting it, in which case we could be overestimating the degree of the respiratory variation.
Correct, and it certainly seemed like in the other images that you showed, there was a bit of swing of the heart in and out of the window as the patient was breathing.
Nice. So does this, what do you think about this then? So if you said that patient might be volume responsive, but we've got an IVC that is fixed and dilated and about, just over 2 centimeters.
So that's, that sort of upper limit, I can't see the measurement. Is it 2 centimeters?
Yeah, let's say it's more than 21 millimeters, because then
so that's dilated. How's the patient? Is the patient ventilated?
Yeah. So the patient, will just go back. The patient sick as a dog. So the patient is on lots of noradrenaline and milrinone, still got poor capillary refill, so in shock.
Oh yeah, sorry.
And ventilated within an inch of, ventilated pretty aggressively.
So in SIM, not breathing spontaneously, presumably. So you'd be looking for the IVC distensibility index in that case, if you're looking for volume responsiveness. But on that M mode waveform there, I can't see any variation at all in the diameter of the IVC. So I agree with you that it's fixed. That does not suggest that the patient would be volume responsive.
Fantastic. So I might just, again, in the meantime, time, just flick through that. And I guess this is the next common scenario that we've got, in that we sort of learn a lot of these, we learn a lot about volume responsiveness when we sort of talk about that, and we go through people with LVOT variation, and then we learn about IVC, and we often, I guess what I'm trying to say is that we often get to the situation where there are different things kind of contradict each other, and that's just the game, isn't it? Where these are the thoughts that I got through it, so that we've someone who's got a normal LV size and a hyperdynamic function, and that's an appropriate response for someone who has then got horrific vasoplegia from septic shock. So that can be a normal response to reduced afterload. We know that you can get normal filling pressures when you've got that, and we've certainly seen that with the normal diastolic dysfunction, so that could fit into the definition of someone who's having a normal response to vasoplegia. The fluid status, from just as Danielle was saying, they might suggest that she's fluid responsive. The flip side to that is, obviously, we know that if we overload someone, particularly if they've got bad lungs, that is a very, very bad thing. And then adding into that is also this idea that she's got this mildly dilated right ventricle with reduced function. And the standard teaching that we've got from that is that if you overload a right ventricle, and we're seeing that bounce, so you're talking about that diastolic wobble, which suggests a volume overload sort of state of that right ventricle, and that's why we're getting that wobble. That'll be another thing suggesting that maybe if we start overloading that right ventricle, that's a very bad thing. But again, with this right ventricle, we've got to try and minimize our PEEP, but then we look at our lung ultrasound, and we had all that consolidation that was in there, and maybe PEEP might help open that up, and that might improve the compliance, improve the hypoxia, and help the hypercarbia, and that might make the afterload for the right ventricle better. And that might actually protect the right ventricle. And so I find it, sometimes echo is a fantastically useful thing, and often it gives me more questions than I had at the beginning, though. And that was what happened with this case. And I think I certainly leant towards the idea of this patient, maybe we don't give fluids. If the RV is at risk, let's not overload it. Just keep going with what we've got. As long as we're not getting massive escalations in noradrenaline, let's just keep going with the milrinone and hold off on the fluid, and we'll go from there.
Can I just suggest that with a large amount of inotropic support, that this heart is not normal.
Yeah, very nice. Yes.
Took the inotropic support away, we might see more obvious signs of heart failure.
Well, great comment. Yeah, so did everyone hear that? Yes, so this idea that you've got to take the clinical context into consideration. And this patient had a blood pressure of 95 systolic and MAPS of about 70, and that was on a lot of NORAD and milrinone. We can have an ejection fraction that was, 55-60% there. And that is not normal under those circumstances with someone who's on to lots of noradrenaline.
I completely agree. When the patient's on a lot of vasopressor, you expect to see their heart going like the clappers, and if it's not, then you know that there must be something wrong with it, and that patient's on milrinone as well. So,
yeah, great call. Thank you.
Maybe too much milrinone.
Maybe too much milrinone. There's no such thing. Lewis, thanks, mate. What a great comment from Lewis that just came up, suggesting that these are the kind of patients, the consideration of proning them, because if you prone them, that can have multiple effects. First of all, we can get better VQ matching, which would improve the compliance, improve oxygenation, and improve removal of CO2, maybe if they're a responder. And it also will help offload the RV and potentially through all those mechanisms being linked through reduced pulmonary afterload. So yeah, great.
Makes it more difficult to echo them though.
And we all know that saves lives, so it's important. Very nice. Cool. So I guess those first two patients were so different, but they're exactly the kind of people that would be included in studies, which is my next problem, I guess, with echo studies, and including some that I've done. You know, you can consider both of these people have septic cardiomyopathies, and that's why I find them really hard. They're sort of two completely different entities almost in themselves. And there are obviously all these challenging diagnostic dilemmas in there, which, you know, tries to, I guess I'm using this as an example that it's really hard to make a definition of septic cardiomyopathy. You know, we are lumping all these guys together in studies, and that's maybe not that helpful, potentially. And then this is another type of one that we saw. This is a fascinating one. I stuck this one in there after, Danielle, we were talking to you last week about the tricky patient with the RV. This is a patient we had who had an infective exacerbation of COPD and came into the unit. They were intubated down in the emergency department, and by the time they came up to us, like 45 minutes later, after they tubed her and sort of settled her in and transferred her, she was on this rapidly escalating noradrenaline requirement. So she had gone from sort of, 5 to 7 mils an hour up to 35 to 40 by the time she arrived with us. And so obviously I pulled out the echo, and this is what we saw. So does anyone, just in the meaning of time, I might just sort of skip through people if that's okay. Oh, no, that's unfair. Lewis, have a crack at this. Lewis McLean. So this lady, a rapidly escalating inotrope requirements, infective exacerbation of COPD, just arrived in the ICU, tubed.
Yes, so apical 3-chamber with colour over the ventricle on the second loop. What seems like is going on is there's a lot of flow acceleration and aliasing in the mid-cavity to left ventricular outflow tract. So the patient's quite tachycardic as well, and seems like they have a small cavity size. So I'd be worried about those escalating vasopressors representing outflow tract obstruction.
Beautiful. So what do you want?
Esmolol.
Nice. Yeah, because this patient got a heart rate of 90. But we've got an infective exacerbation of COPD. I guess that's what we're coming on to. Well, first of all, I'll give you color wave Doppler first. What do you think?
So that's through the color wave Doppler through the aortic valve. So that's.
Whereas I said a continuous wave Doppler. Sorry, I said color wave. My
sorry, and I repeated it. That's quite a high velocity.
Yeah.
At 5.5, yeah. So that's quite a high peak velocity. Obviously, not sure whether that represents the velocity through the valve or somewhere along the line of that continuous wave Doppler.
Yeah, and I had the same thought. Can I just, before I go on, can you notice there are different daggers in there? We've got one that's a smaller one that's around about the 2 meters per second. Here's probably a better way of showing it. And then there's also this one down here. And I went back and had a look at this, and I think we probably got two areas of obstruction. One is by the sigmoid septum. So this is a common feature in those with some form of persistent, particularly old people who've got lots of high blood pressure. You get this sigmoid-shaped septum, which gets a little knuckle that comes out there. And most of the time, that doesn't cause any problems. But unless you get hypovolemic, and you get a bit of RV dilation because you've got maybe an RV that's not perfect beforehand, and then you get sick with the infective exacerbation of your COPD, and you get acidotic and hypoxic and hypercarbic, and your RV then gets worse and it pushes over the septum. And suddenly you can get these kind of pictures, which is, and Danielle had one of these, sounded a bit similar to this last week. And these guys I find them really hard to know how to treat. So, because Lewis, you're saying you could esmolol them, so you can give them. So the idea is that the treatment that we're giving with the noradrenaline is making things worse potentially. So instead of giving them a beta agonist to try and make their heart beat faster, Lewis now wants to give her a beta blocker to slow down her heart.
So the first thing I would do is optimize the LV filling pressure, and that would probably be with fluid.
But she's got a dilated RV because she had an RV at risk.
Yeah, and use probably lower doses of vasopressor preferentially, and because obviously that's the higher dose of noradrenaline is going to increase the beta effects, and then consider the introduction of a beta blocker, and preferably a short-acting one that can titrate.
Yeah, and I think also trying to do anything to minimize the dilation of the heart. So maybe, try and reducing the PEEP, but the echo definitely changes the way that we look at this patient, but again, often helps bring up more questions than we have obvious answers. And I think every single treatment option has risk, from bronchospasm with a beta blocker potentially through to fluid overloading a right ventricle. And so I think you've got to do it really slowly and with repeat examination. And it's really hard, isn't it?
Yeah.
Can I just mention, Sam, because Lewis talked about aortic stenosis versus LVOT obstruction.
Yep.
So I think the first thing to look at would be the 2D image that you had on the previous slide, and then you'll notice that the aortic valve is actually opening pretty okay. So gives you a bit of an indication that maybe aortic stenosis is less responsible for that velocity than something up downstream in the LV. And then the other thing would be to look at the Doppler profile that Sam had up. So late peaking, you're more likely to see it in an obstructive physiology, whether it be mid-ventricular, mid-cavity, or LVOT. And then with a severe AS, you see it really doesn't go further than a mid-peak. Is that fair to say, Sam?
Yeah, and so you talk about stepping back with the pulse wave Doppler and taking images along the way, trying to find out where the obstruction is.
Exactly, yeah.
Nice. Very nice. And with this one, I think we saw it all the way back, so I'm sorry I don't have the pictures, but you can see it at the level of the septic knuckle, which is where I think the larger late peaking jet is, or was it the saber shape to this? And then you also got a smaller one in there from the mid-ventricle cavity as well.
Dagger shape.
Yeah. Isn't there a type of sword though that's got that kind of? There was a Turkish sword. This is a really nice study. The two studies. I'll only put up two papers here. So this is the first one that's done by our friend Michelle Slama, and they did this study, multi-center study. 218 patients, which is one of the larger, obviously, echo studies that's been done over a 28-month period. And so it's just to generalize, so it's just single center study, excuse me. And they looked at the difference between those who had some form of obstruction, so some form of that late peaking jet on their image. And so that was often just on Doppler, not just 2D. And they had a look at their mortality versus those that didn't have that. And they were using this idea as this might be an indication of being hypovolemic. So that if you got that late dagger shape, you got that obstruction, that hyperdynamic circulation is associated with hypovolemia. And they found a pretty impressive difference in the mortality between these guys. So a not insignificant patient group. Mortality at 28 days, which isn't a terrible endpoint. And they found that small hypercontractile left ventricles and ejection fraction 82, and frequent pseudo-hypertrophy. So pseudo-hypertrophy means that the walls look thick in an underfilled left ventricle. So be really careful about calling hypertrophy in an underfilled ventricle. Blah, 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 blah. And they found that mortality rate, 28 days, was higher in patients with interventricular obstruction than without, 55 versus 33%. So it kind of makes sense to me that this is where I have an idea that hypovolemia is bad in our patients, just as too much is, and goes with, as Ian Seppelt says, the Goldilocks principle. So you just got to get it just right, which is incredibly difficult. Okay, so let's do so again, that lady also could be considered to have a septic cardiomyopathy because she was sick and on inotropes. And again, very different pathology that's going on compared to the other two. And then let's consider this one here. So we haven't mentioned one of these. So this is a 65-year-old lady. She had community-acquired pneumonia. She had a background of COPD as well. She ended up having a metapneumovirus positive infection. We thought she might have a bacterial superinfection on top of that. And she was on a not insignificant amount of noradrenaline. This was her image. She was put on NIV for 24 hours, and we could probably talk a lot about that, about giving someone with a chest X-ray like that NIV for 24 hours, which I'm not sure is right. But anyway, it's about echo, not anything else. What do we think about this? Who have we not hammered? Ali. Hi, Ali. Are we allowed to ask you a question? You'll like this. You there, Ali? All right, we won't ask Ali. Ben, you want to have another go at something? If we help you out with it?
Yeah, why not? Yeah.
All right. So what I want you to look at in this picture of someone who's so it's a sort of elderly lady. I think she's in her 70s, wasn't she? But then gets sick on inotropes and not an insignificant amount. And we're obviously looking at an echo. And what I want you to have a look at here is the talk to me about the regional abnormality, because this is obviously a ventricle that's not working well. But can you talk to me if you think that there are any parts of the heart that are moving better than others?
So on my projection of the screen, there's an apical 4 chamber that looks as though the LV apex is not moving as much as it should.
Excellent.
I think that there's, of the entire left ventricle, the apex is down the most. The septum as well appears to be down. Based off the history that you've told me, I'd question whether there's, we know it's septic cardiomyopathy, but whether this is a more like a Takotsubo strain.
Fantastic, mate. Good work. And the little sort of tip and trick I use with this is if I look for what's known as a hinge point. So it's one of our sonographers taught me about this. So can you see my mouse? If I just look at that, which I think is almost the like the border between where the basal segments are and the mid segments, and I reckon it looks like the mid segments are doing nothing, but the basal segments are contracting much more, and that's where we can start seeing the regional wall motion abnormalities. And I think it's the same on the other side. And if we look at it in the subcostal view, that kind of looks the same with we call it relative basal hyperkinesis relative to the apex. And absolutely, that can fit with the Takotsubo. How would you, how do you be sure? Give me something else. Whenever you talk about Takotsubo, you've got to say it's a diagnosis of exclusion.
Yeah.
And why is that? What do we need to exclude?
I'd imagine you need to exclude coronary artery disease.
Yeah, particularly which one?
Down the right coronary. Or
LAD, actually. So LAD at the top. I mean, I guess it can be the right coronary. Coronary arteries are funny old things, aren't they? But typically they're talking about LAD occlusion, because that's what can do the apex and the mid-ventricle potentially. Okay. But yeah, it could be the right coronary. I think classically they talk about the LAD territory infarction, and hence, based on the Mayo criteria, they'd say that you've got to make sure you've got a normal angiogram, and this is reversible, obviously, after about 72 hours, and you've got some kind of prodrome to it, and it's in sort of the right population, which is postmenopausal women, classically. So yeah, very nice. So absolutely, I was agreeing with you, saying that, is this a Takotsubo cardiomyopathy? Make sure that's a diagnosis of exclusion. I often treat them as non-STEMIs until proven otherwise.
Yeah.
So make sure we say it's a diagnosis of exclusion. But again, this is a very different beast from the other 3 cases. But again, we would include all of these together. Just we've got a couple of minutes. I'll flick through the rest. Just, I guess we talked about what's, on the basis of that, this is some of the best literature that we've got that says, originally, about 20, 30 years ago, they were saying that if your LV was down, that was actually a good prognostic sign. And the theory behind that was that if you had worse vasoplegia and worse sepsis, that's when your heart would be working harder. So that if you had a bad LV, it actually meant that maybe your afterload reduction wasn't as bad as the rest. We've had some pretty smart people, like Antoine Villabaron, suggest with evidence that came out maybe 10 or so years ago that might not be the case. And actually it was, the dysfunction wasn't associated with a poor prognosis. It was sort of more that we'd see this global left ventricular hyperkinesia in about 30 to 40% of patients, similar to other studies. So that's 60% incidence with these guys. Obviously, we now got 14 studies. We've got to do a meta-analysis on that. And the meta-analysis done by some of the guys here, Stephen Huang Marek and Prof, as well as, again, Juan Pulido over in the States, suggesting that putting all those together, the LV dysfunction assessed by ejection fractions, probably not the main prognostic factor. So if you see someone with it, it does not mean that they're going to have a bad outcome, whether they've got a bad or a good heart. In terms of LV size, putting all those studies together, yes, maybe there was a little bit of an instance suggesting LV dilation was associated with worse outcomes. In terms of diastolic dysfunction, the diastolic dysfunction as well was suggesting that if you've got diastolic dysfunction, that might be associated with worse outcomes. Again, systolic functions, no. But let's not forget the right ventricle. And the right ventricle, again, studies such as some pretty dodgy ones that I've done, suggesting that if the right ventricle's down, that's a bad prognostic sign. And that probably won't surprise anyone on listening to this. But you put that with lots of the other data and it doesn't back up exactly what I found. And that's because all the other subjects are wrong, obviously. And I don't mean that. But this is the big one that I wanted to talk about. So I think all of those studies that we've talked about that give us those prognostic implications, good prognostic markers, they're not magic because we've just shown 4 different patients that we'd see all the time. I don't think any of those would be unusual to you guys who are doing a bit of echo and the critically ill, and yet we'd include them all in the same studies and lump them all together, and then we make these sweeping statements like the LV function doesn't matter in prognostic outcomes. And I think it's just far more complicated than that. And that's where studies like this one from Iman Desap are really good, where he started to have a look at the LV function, but not as a marker by itself, but in the context of afterload. So he found that there, for example, he found ways of assessing sort of end systolic wall stress. And obviously the worse the wall stress is, the worse your ejection fraction is. And he starts to have a look at it together. So the idea is that you can't take just the ejection fraction or the systolic function by itself. You've got to take it in clinical context of assessment of the afterload and filling status, which again makes sense to me. And he found some beautiful correlations that would back that up. Again, all done with simple parameters that we do on echo and non-invasive imaging. And so they found an inverse correlation between most of the contractility and afterload indices. It's doesn't seem remarkable, of course, but it's, I think, again, it's one of the first studies that I've seen with echo where they're actually starting to try and have some form of, you call it clinical context, I guess, which feels to me to be very important in looking after the patients as we discussed in the cases. So yeah, precise evaluation of afterload is crucial for adequate interpretation of LV systolic function in this setting. And that makes absolute sense to me. So other issues around the studies, we often don't have follow-up for these things. We say it's reversible and that's a good thing. We don't have often clearly defined follow-up. So we're often not talking about change in function. We're just looking at a snapshot in time. And that doesn't seem to be accurate sometimes. We often can't consider people's previous cardiac function. And so it's hard to say whether a lot of this is acute or chronic. All the studies have different definitions of ventricular failure, be it me using strain or someone else using TAPSE or someone else using subjective estimates or other people using, dodgy studies that maybe we wouldn't include for robust analysis if we were reporting it. I think we've got to be really careful when we're assessing the literature to try and make sure that, they're well done. And finally, I guess having a definition of sepsis and who's being included. And sometimes, as I think we'll all know, that we use sepsis as a diagnosis when sometimes it's far from certain. But these patients are often included in all these studies. So I think these are really difficult studies to do, to be honest. And but I think moving forward, we should be trying to have decent inclusion criteria, try and make sure that we're not including rubbish studies. Maybe we just consider select groups of patients that don't have any signs of hypovolemia, that we say that their volume status is as accurate as we can. We make sure they've got no Doppler pictures of LVOT or interventricular obstruction before we include them in a septic cardiomyopathy study. And things like that. It means these studies are harder to do, but again, points to the idea that maybe we should be all doing them together and trying to gather data that way, doing it as a group rather than as individuals. So final in conclusion, I think we'd say that, obviously echo is phenomenally useful, I think, in managing these patients. And we've saw in the cases that we presented how echo is sort of fundamental to try and decide how to move forward. it can sort of generate more questions than answers sometimes, but that's clinical medicine, isn't it? I think we know that LV dysfunction can occur in somewhere between 40 to 60% of patients, RV function about 40 to 60% of patients. If it's reversible, that's a good thing. It's affecting both systolic and diastolic dysfunction, both ventricles. And of course, if we're trying to make any form of assessment of these patients, you've got to take clinical context into consideration and looking at the patient as a whole, not just as individual bits. So that's it. I'm sorry we don't have time to go through the cases, but maybe we'll just ask if there are any comments.
I had a comment.
Hi.
Basically, you mentioned in the other issues, we have to consider what sort of support the patients are on, what sort of ventilation, whether they are on CRRT therapy, what sort of ionotropes they are on.
Yeah.
And so we really, when we interpret the studies or when we conduct further studies, these all factors need to be included.
Yeah, absolutely, and I completely agree. And Louise said the same thing. And forgive me if I have not highlighted that enough. That's where the clinical context is everything. Both as well as considering do they have underlying heart function before this, but also how much support they're currently on. And someone with an ejection fraction of 60% on no support is very different from someone who's got an ejection fraction of 60% who's on double strength NORAD and levo and a bit of adrenaline. Yeah, absolutely, I completely agree. And forgive me if that wasn't highlighted enough.
But one more thing, what we have noticed with increased use of APRV mode and inhaled pulmonary vasodilators, that also affects the way heart behaves and how we see the heart when doing echo in these conditions.
Really? So you reckon you're seeing so you use a lot of APRV? Because I'm a big fan of that mode of ventilation as well. And you're finding that the hearts behave differently, do you, when you use APRV?
Yes, especially the filling of the right ventricle, it is very much affected by our I ratio, and if the ratio is too high, there's very little time for the, I've seen in a few IVCs emptying into the RV, right atrium.
That's fascinating, buddy. We got to talk more about that, because I think that's a really interesting thing that I haven't seen a lot of data talking about. In terms of heart-lung interactions. And I think that's potentially a group of patients that could be at harm potentially from APRV. And of course, that's where you've got to consider the heart and the lungs. So that's really interesting to look at. Maybe would you be up for maybe presenting a case or two on the use of this in one of these forums?
Sure, I can do that.
Amazing. Thank you very much indeed. Well, guys, if there are no other comments, maybe I'll say that's probably time, and I'll see you guys next week. Thank you very much for listening.
Thanks, Evan.
Thank you.
Thanks.
Thanks, Sam.
Thanks, Sam.
Bye.